So this is also another important image for you, right? So where you are able to see a cross section of umbilical cord, and the most frequently asked question here is how many vessels are present in the umbilical cord and what are they? Yes, you have 2 umbilical arteries and 1 umbilical vein. Okay, sorry, and 1 umbilical vein. Okay, so that is very important for you. So this is to be remembered. Okay, you have 2 umbilical arteries and 1 umbilical vein. Okay, so which vein is left? Yes, the left vein is left and the right vein usually disappears during your 4th month of gestational age. Okay. Now, one of the common anomaly that is associated with the umbilical cord is single umbilical artery. Okay, a condition where only 1 umbilical artery is present. Okay, so that is commonly seen, and when this is present, you have to look for any associated congenital malformations. It can be in the cardiovascular system, renal system, or genital system, and this is also associated most commonly with your trisomy, especially trisomy 18. Clear? Yes. Now, let's see this. Speaking about fetal circulation, which is a physiology, is also very important in this section because so many questions on your fetal circulation has come in various papers, right? Yes. First, let me discuss the physiology here, then we will discuss some of the important points of fetal circulation. Okay. So, it all starts from the placenta. Okay, let's start from the placenta first. So, we have the placenta here. Okay, and which is going to carry blood to the fetus? It is going to be the umbilical artery or the umbilical vein? Yes, it is going to be the umbilical vein which is going to carry the pure blood or the oxygenated blood, right? Yes. So, blood will be carried by the umbilical vein, and from the umbilical vein, the blood has to reach the inferior vena cava. Okay, so keep this as the destination. But before coming into the inferior vena cava, the most of the fetal blood can be shunted into the portal circulation. But we doesn't want this to happen because it is going to be only a wastage. Okay, so the blood from the umbilical vein will be directly shunted into the inferior vena cava by a shunt called ductus venosus. However, some of the blood may enter into the portal circulation also, but however, they will also be returning to the inferior vena cava. But maximum of the blood will be shunted directly into the inferior vena cava by the ductus venosus. Also, this inferior vena cava will be receiving blood from the lower limb as well as kidney also, right? Now, from the inferior vena cava, the blood will be reaching where? It will be reaching the right atrium. Yes, we all know right atrium is also going to receive blood from the superior vena cava, right? It is going to receive blood from the superior vena cava, and superior vena cava is going to drain the head as well as upper extremity, right? Okay. Now, we have the blood in the right atrium. Now, from the right atrium, we have 2 parts. Okay, either the blood can go into the left atrium or into the right ventricle. Okay, but both are going to happen. Let us first discuss how the blood is entering into the left atrium. Okay, so to enter into the left atrium, there is another opening here that is called as foramen ovale. Okay, so through the foramen ovale, the blood from the right atrium is now entering into the left atrium. Okay. Now, from the left atrium, the blood will go into the left ventricle and finally it will reach the aorta. I am writing it as A alone. Okay. Aorta, and from the aorta, blood will be reaching the head and upper extremity, the oxygenated blood, as well as it will also be reaching the other viscera and lower extremity or lower limbs, and it will also be entering the umbilical artery. Okay, umbilical artery and will be going back into the placenta. Okay, so this is one route. Another route is that the blood which is entered into the right ventricle will now be going into the pulmonary artery. Okay, because we already know the lungs are non-functional in the fetus, right? So the blood that is going into the pulmonary artery is going to be again a wastage. So what is going to happen is 90% of the blood which is going to enter into the pulmonary artery will be shunted back into the aorta through a duct called ductus arteriosus. Okay, and finally we also have blood supply to the lungs that will be going through this pulmonary artery and it will be reaching the pulmonary vein and entering into the left atrium. Clear? So all these points you have to keep it in mind. The important point is we have 3 shunts here. Okay, how many shunts we have? We have 3 shunts. Okay, so one is ductus venosus, another one is ductus arteriosus, another one is your foramen ovale. Clear? So this is a very rough picture, but I hope you would have got the point how the blood is circulating and it is distributed. Okay, and between what and what the 3 shunts are present, that is also important, right? Yes. Now let us discuss the change that is going to happen after birth. So what happens soon after birth? We are going to clamp the umbilical cord. So as we clamp the umbilical cord, the blood system which is a high pressure system in the lungs is now going to become a low pressure system and there will be rise in the systemic vascular resistance, right? Okay. Now let us discuss the difference between the fetal circulation and the infant circulation. So fetal circulation, these are all not asked in your exams, but I hope when you learn this you will get a better understanding of fetal circulation. Okay, so fetal circulation and infant circulation. So fetal circulation is usually low pressure system, whereas infant circulation is going to be a high pressure system. And in fetal circulation, most of the shunts are going from the right to left, whereas in infant it is going to be left to right. And we know in the fetus the lungs are non-functional, right? Whereas in the infant these are going to be functional. And since the lungs are non-functional, there is increased pulmonary vascular resistance in the fetus, whereas here there is decreased pulmonary vascular resistance, and in the fetus there is reduced systemic vascular resistance, whereas in the infant there is increased systemic vascular resistance. Is that clear? Right. Now let us also discuss about the changes that is happening in the different shunts, okay, when they are closing and what is happening to them, right? Okay. Now let us discuss about the shunt here and also about the functional closure. Anatomical closure as well as any remnant that is present. Okay. So let us discuss what is happening to your ductus arteriosus, foramen ovale as well as ductus venosus. Usually functional closure of ductus arteriosus happens between 10 to 96 hours after birth, and complete anatomical closure will be seen by 2 to 3 weeks of birth, and the remnant of ductus arteriosus is going to be your, yes, very good, it is going to be your ligamentum arteriosum. Okay. The same way foramen ovale functional closure will be happening within several minutes, okay, within several minutes after birth, and anatomical closure will be happening after or by 1 year of birth, and the remnant of this is fossa ovalis, right? And the next one is ductus venosus. This also closes by functionally within several minutes, and anatomical closure will be happening within a week, okay, that is 3 to 7 days after birth, and the remnant is nothing but your ligamentum venosum. Yes, So you have to know this table thoroughly. Okay. So these are also regions where different questions were asked. Okay. This table is important. As well as you have to know the remnant of umbilical arteries or your umbilical ligaments, as well as umbilical vein. Remnant is your ligamentum teres. Clear? So this is all about your fetal circulation. Now let us discuss about the fetal skull. Okay. So we are going to name this fetal skull now, and I want you to work with me together, right? Yes. So first let us see what are the bones present and which are the important landmarks. Okay. So we all know this is going to be your frontal bone, this is your parietal bone, and this one is your temporal bone, and finally we have the occipital bone here, right? Let us see some of the important landmarks as well. The first one is going to be your glabella, okay, here, and then you have this one, this is occipital protuberance, this one is going to be your mentum, okay, and we have sutures also. What is this suture? This suture, because we are seeing the lateral, seeing the skull from lateral side, this is going to be your coronal suture, and this is going to be a lambdoidal suture, right? We have two fontanelles here. This is anterior fontanelle or bregma, and this is your posterior fontanelle. Okay. Now I want you to understand that whenever a fetal head is presenting, the whole presentation is called as cephalic presentation, but there are so many different regions of this cephalus. Okay. So the region that is present between the anterior fontanelle and the posterior fontanelle is only the vertex. Okay. So this is vertex. When this region is presenting, then only we call it as a vertex presentation. Suppose the region between the anterior fontanelle and the glabella is presenting, then it is going to be a sinciput presentation. Since then sinciput is presenting, that means your brow presentation. Okay. Suppose glabella and mentum is presenting, this will be your face presentation. Clear? But this region is sinciput, the same way the one that is present between the posterior fontanelle and the occipital protuberance is going to be your occiput. Clear? So this is all about your fetal skull. No confusion, right? Yes. Now let's also see this view of fetal skull, where you are able to see the sagittal suture clearly. Okay. So this is the upside view of fetal skull. So this is the sagittal suture you are able to see, right? So the suture coming here is your lambdoid suture. Yes, this is your anterior fontanelle, and this is your frontal suture. Okay, the one that is separating the frontal bones is your frontal suture. Okay, so this is your anterior fontanelle, and yeah, this is your occiput. Okay, these are your parietal eminences. This is your parietal bone, right? Okay. Now, let us see some of the important diameters here. You have three important diameters. Okay. So, one is your biparietal diameter that is present between the two parietal eminences. Okay. And you have the bitemporal diameter that is present between the two temporal bones roughly here. Okay. So, you have parietal diameter and bitemporal temporal diameter. Okay, and you also have a supraseparatal diameter also. I'll explain that later. Now let us discuss the diameters of fetal head. We have anteroposterior diameters of fetal head as well as the transverse diameters of fetal head, right? So let us discuss about the anteroposterior diameter of fetal head. We'll be discussing the whole concept now. Okay, so we'll discuss the attitude and what will be the diameter and what it means actually. Okay, definition of that particular thing and how will be the measurement and what will be the presentation if that particular diameter is presenting. Okay, so this table is very important for you. So attitude means how the fetal head is going to be, in what position. It can be a complete flexion or it can become an incomplete flexion or it can become a deflexed head, that is a military position, or it become partially extended or completely extended. Can you imagine? Right. So these are the attitudes we are going to discuss. So first one is complete flexion. The diameter of engagement here is going to be a suboccipito-bregmatic diameter, that is just below the occipital bone. Okay, just below the occipital bone. Just below, okay, that I'll write it as JB. Just below the occipital bone to the anterior fontanelle. The measurement of suboccipito-bregmatic diameter is roughly 9.5 centimeter and the presentation is going to be vertex. Okay, then it becomes incomplete flexion, right? So in incomplete flexion, the diameter of engagement is your suboccipitofrontal diameter. Suboccipitofrontal means, so here also it starts just below the occipital protuberance, but it goes to the center point of the anterior fontanelle, or we can say sinciput. Okay, so the measurement here is going to be 10 centimeter and the presentation is again vertex presentation. Clear? Right. And the next attitude is deflexed attitude, where the diameter is going to be occipitofrontal and it is from the most important point of occipital protuberance to the glabella. Okay, the measurement of occipitofrontal diameter is going to be 11.5 centimeter and here also the presentation is going to be vertex presentation. Clear? Next is your partial extension attitude, where the diameter of engagement is going to be your mento-vertical diameter. Mento-vertical diameter means it extends from the chin to the furthest point on the vertex, right? This is one of the largest anteroposterior diameters of the fetal skull, which is going to be around 14 centimeter, and this presents in bro presentation. This is very important, right? And the next attitude is going to be your incomplete extension. In incomplete extension, the diameter of presentation is going to be your submento-vertical diameter. So it starts from the junction of the floor of the mouth to the highest floor of mouth, to the highest point on the sagittal suture, and this measures around 11.5 centimeter and the presentation here is, repeating once again, and the presentation here is going to be a face presentation. Okay, so in face presentation it is the submento-vertical diameter that is presenting, right? And the next one is complete extension. Complete extension attitude means the diameter of engagement is going to be a submento-bregmatic, and here it starts from the junction of the floor of the mouth and it goes to the center point of the anterior fontanelle, center of anterior fontanelle. Okay, so here the measurement is around 9.5 centimeters and here the presentation is again your face presentation. Okay, so one of the important measurement you have to remember here is for bro presentation. Okay, others are also asked, but bro presentation is tested frequently. Okay, so now why I had to explain all the things? Suppose if you get a pic like this and they have asked A, B, C, and say what is C and what is the measurement. So, first you have to know how to identify the various measurements, right? Then only you will be able to answer what it is, right? So, first you have to identify it as frontal bone, this is the vertex, this is the occiput and this is the mentum, okay. So, one and obviously this is your bigma, right. One that is passing from the frontal bone to the occipital bone is going to be your occipitofrontal diameter. So, one that is passing from the mentum to the vertex is going to be your mentovertical diameter. So, this is your submental region and from there it is going to the bregma. So, this is going to be a submentobregmatic diameter and this is suboccipital region. From the suboccipital region it is going to the bregma. So, it is going to be a suboccipitobregmatic diameter. Clear? Right. Now, I told you the measurements also, even if they ask you the measurements, you should be able to do, and remember the presentation is also tested often, right? Yes. Now, coming to the transverse diameters of fetal head, okay. So, transverse diameters of fetal head. So, let us talk about the diameters. The definition as we saw before and measurement. Okay. So, the diameter first one is going to be a biparietal diameter. This is present between the two parietal eminences. Okay. So, between two parietal eminences and this is going to be 9.5 centimeter. Okay. Next is, it is your bitemporal diameter. It extends from the antero-inferior end of one coronal suture to the other. Okay, so that is bitemporal diameter and this measures around 8 centimeter or you can even remember it as 8.5 centimeter easily. Okay. Next is your bimastoid diameter that is present between the two mastoid process. So, this measures roughly around 7.5 centimeter. So, it is your PTM, okay, biparietal, bitemporal and bimastoid, and among this the maximum transverse diameter is going to be your biparietal diameter and the smallest transverse diameter is going to be your bimastoid diameter, okay. Yes, and also you have to know one more diameter, that is your super subparietal diameter, okay. It is your super subparietal diameter. Now, it extends from the lower end of one parietal prominence to the upper end of another parietal prominence, okay. So, if you see this picture, you will be able to understand, okay. So, this is the parietal prominences. So, from here, lower end of one parietal prominence to the upper end of another parietal prominence, we are drawing a line. So, this is your super subparietal diameter and super subparietal diameter roughly measures around 8.5 centimeter, okay. And in asynclitism, this is the smallest transverse diameter which is engaged, okay. This is important in asynclitism, right. Now, let us discuss about the various changes that the fetal skull is going to face when it is going into the labor process, right. So, one important process it will be undergoing is molding, because the fetal skull is not that much ossified. Also, you have so many sutures, right. So, it will go for molding easily, which facilitates the delivery, okay. As it is passing through the various diameters of the pelvis, it will be molding itself, right. So, degrees of molding is also very important for you. We have 4 degrees of molding, 1 plus, 2 plus and 3 plus. First is 0, okay. So, here what is 1 plus means? The suture lines are separate, right, and 1 plus means suture lines meet. Then 2 plus, here also suture lines meet but can be reduced, okay. If you give digital pressure, then you will be able to reduce it. And finally, here there is overlap between the bones and it becomes irreducible. Clear? Right. Now, if you see this, you are able to see 0 plus molding where the suture lines are separate. Okay, so there is a gap here, right? Then 1 plus molding, the bones are touching each other, and in 2 plus molding, the bones are trying to overlap, but with digital pressure, you will be able to overcome this. Okay, and finally 3 plus molding where the overlap is there, but you are not able to overcome the overlapping. Clear? Yes. So, this is about molding, and also you have to know about the 2 different conditions that will happen. You will be able to, repeating once again. Now, let us also discuss about the 2 different swellings that you will be able to see in the fetal skull after birth. Okay. So, these are caput succedinum and cephalometoma. Okay. So, the differentiation between these 2 is frequently asked, and clinically also you should be able to differentiate between these 2, right. Now, let us discuss about caput and cephalometoma. See, caput is something which is present always at birth. Okay. During birth itself, you will be able to see this. Whereas cephalometoma is not present at birth, but this will develop within few hours after birth. Okay, even after some days also this can develop, right? And next point is, caput is not a well defined one. That means it is not limited by any suture. Okay, not limited by suture. Whereas cephalometoma is well defined one, and it is limited by suture. Caput is soft swelling and it fits on pressure, whereas cephalometoma is soft, fluctuant and generally not compressible. Okay, not compressible, and it is usually tender as well. Okay, there is tenderness also, right? And finally, caput disappears within 24 hours, whereas a cephalometoma takes 6 to 8 weeks to disappear. Clear? Yes. Now, if you see this picture, what you are able to see? You are able to see dark patches on the cheek of the woman, and she might be pregnant, right? So, what is this? It is chloasma. And what is this line? Something you see a straight line that is extending from the xiphisternum to the pubic symphysis. This is going to be a linea nigra, right? So, I put this 2 together because the reason for this being seen in pregnancy is also the same. Okay, so there is melanocyte stimulating hormone that is elevated from your 2nd trimester till term. Okay, so that is going to be the cause. Also, the other hormones, say estrogen or progesterone, are also seen to have some melanocyte stimulating effect. Okay, so that is why you are seeing this dark colored patches as well as this dark line that is running from here to here. Okay, so this pigmentation usually regresses after delivery, right? So that is very important. And what is it? Yes, this is your striae gravitarum, right? So this is your striae gravitarum, and this is caused due to mechanical stretching of the skin. Okay, the cause for this is mechanical stretching of skin. Okay, and it can also be associated with increased secretion of ACTH that is affecting the connective tissues, right? Now, this picture is also important for you. You should be able to make the fundal height, and you should be able to tell what is the corresponding gestational age, right? So, the point of marking is your umbilicus. Okay, so below umbilicus we have 3 divisions, and above umbilicus will be dividing it into 3 partitions. Okay, so that is very important. Now, this is 12, that means the uterus becomes just palpable by 12 weeks. Okay, so just palpable. Then by 16 weeks, it will be divided into 1/3, okay, from the umbilicus. But from the umbilicus and the pubic symphysis, you will be dividing it into 3 parts, okay, and the lower 1/3 part will be corresponding to 16 weeks, and the 2/3 part will be corresponding to 20 weeks, and at the level of umbilicus, it is exactly your 24 weeks. Clear? And above umbilicus also we will be dividing it into 3 parts, that is from the umbilicus to the xiphisternum. Okay, so the lower 1/3 between the umbilicus and the xiphisternum is going to be your 28 week, and then it is going to be your 32 week, that is lower 2/3, and at the level of xiphisternum it is going to be your 36 weeks. And by 40 weeks, what is going to happen? It is going to descend back and come to the level of 32 weeks once again. But remember, at 40 weeks, the flanks are full. Clear? Now, you should know the conditions in which the uterine height is more than the expected gestational age and when it is less than the expected gestational age. Okay? So, when height of fundus is more than the period of gestation. So, either it can be due to wrong dates or the baby can be more, that is multiple pregnancy, liquor amni can be more, that is polyhydramnios, or the baby can be very big, that is macrosomia, or there can be fibroids or any tumors in the uterus. And placental abnormality, yes, abruption placentae where there is a concealed hemorrhage can cause this. Okay, always when you are trying to rule out the causes, you have to start from the uterus. Okay, so maybe the uterus, then the placenta, then the liquor amni, then the baby, or from the inside to the outside will be done. Clear? Next is when the height of the uterus is going to be less than the period of gestation. So again, it can be due to wrong dates. That is one of the most common cause. Yes, it can be due to oligohydramnios, or very important, it can be seen in transverse lie as well, and it can be seen in IUGR or IUD, right? Yes. Now, yeah, coming to here, I want to speak about the lie only because I mentioned something called transverse lie, right? So, what is lie actually? Lie is the relationship between the longitudinal axis of the uterus, okay, with the longitudinal axis of the baby. Okay, so longitudinal axis of the uterus and longitudinal axis of the baby, this relationship is called as lie. Okay, so normally a lie can be longitudinal lie, transverse lie, or an oblique lie. Most common lie is longitudinal lie. Remember, a longitudinal lie can have 2 presentations. It can be a cephalic presentation or it can be a breech presentation. Okay, so that is a different part. We will talk about it later. Now, for now, remember, a lie can be longitudinal lie, transverse lie, or an oblique lie. And I told you the relationship between the uterus and the baby should be seen. So, the uterus is also longitudinal here, baby is also longitudinal here. So, this is going to be a longitudinal lie, right? So, if you see in this picture, the uterus itself is tilted. Okay, the baby is also seems to be tilted, okay, deviated from the longitudinal this axis, right? So, both are deviated because of dextral rotation. Dextral rotation is common during pregnancy, right? So, when you correct this dextral rotation, both the uterus and both the baby are going to come in the central axis, right? That means both of them are again in longitudinal line, right? Yes, this is done. Okay, then this one is oblique line, okay, because the uterus is in the normal position, whereas the fetus is in the oblique line. Can you understand? So, here the uterus is in a normal position, whereas the fetus is lying transversely. So, this is a transverse line. Can you understand? So, you have to see the relationship of the fetus with that of the uterine axis. Clear? So, that is about the line. And the most common presentation that you have when you have a transverse lie is shoulder presentation. Sometimes if they give you this picture, this is a picture of neglected shoulder presentation. Okay, neglected shoulder presentation can lead to so many problems. Okay, so it can lead to impaction and wedging of shoulder. See how the shoulder is impacted here, right? And it can lead to obstructed labor, that is one important complication. Obstructed labor that can result in dehydration, ketosis, sepsis, and at last but not the least, it can even result in uterine rupture. Okay. Now, whenever you see a neglected shoulder presentation, first is maternal resuscitation. Okay. So, you will go for IV fluids, antibiotics, then also blood transfusion if necessary, right? Then depending upon the baby is alive or not, you will plan the further management. Suppose if the baby is alive, then take her to a cesarean section and perform laparotomy, okay, procedures, associated laparotomy procedures also if needed. Suppose if the baby is dead, then you can even try destructive surgeries including decapitation, evisceration, but these days destructive surgeries are not performed that much, right? Okay. Now, this one is also important for you. We are going to discuss about the positions. Okay, so many confusion and so many questions on this. So, first what I would advise is you have to see 3 points, okay, whenever you are asked about a position question. First point, see where is the pubic symphysis and the sacral promontory. PSSP you should make it. Okay, always pubic symphysis is anterior and sacral promontory is posterior. Okay, and the second one, okay, so this is in the maternal pelvis. Second, you see the fetal picture that is given, fetal skull picture that is given. So, in that you have to identify where is the occiput. Okay, so look where is the occiput. And third, always remember the picture will be given like you are examining the patient. Okay, so always your right is patient left and your left is patient right. Okay, so identify the side of the patient. Okay, if you do these 3 points clearly, then you will be able to arrive at the answer. Okay, so that's it. Now, let us do this example. Okay, let us forget what position it is. Okay, now first I am seeing this alone. Okay, so first I am going to make out where is the pubic symphysis, where is the sacral promontory. So this is my pubic symphysis, this is my sacral promontory, and of course this is your anterior side and this is your posterior side, right? Then number 2, we will look at the fetal skull and we will look where the occiput is, right? So here is the occiput, right? And then I will make the right and left side of the patient. So, this is the right side of the patient, that is towards my left, and this is the left side of the patient, that is towards the right. Now, where is the occiput located? It is located posteriorly and it is located on the right side. So, what position is this? This is right occipito-posterior position. Clear? So, yes, this is a right occipito-posterior position. This is how you will do. Clear? Right. So, yeah. And I want to discuss about this specific position. Okay. So, most of the occipito-anterior positions will be having a normal examination, but in occipito-posterior position, you will have some difficulties in labor as well as there will be trouble to the mother as well, okay, and you will be having different findings while you do examination or inspection. So, this specific occipito-posterior position is a question that is asked to you frequently, right. So, what are the clues that they may give regarding this occipito-posterior position means? First, they will say the complaints from the mother, okay, that she has an urge to pass urine because this is going to compress the bladder. The occiput is going to compress the bladder now, right. Then on inspection, intra-umbilical flattening is seen. Okay, intra-umbilical flattening is seen. Okay, you are able to see the intra-umbilical flattening, but because when occiput anterior position is there, this occiput will show this picture, that is there will be elevation in the lower part of the abdomen, whereas when it is occipito-posterior position, this intra-umbilical flattening will be there. Okay. And the third clue they may give is fetal heart sound is heard on the lateral side and the mother has premature bearing down. Okay, she has an urge to bear down as well. Okay, so if all these points are given to you, then you have to identify this as occipito-posterior position, right? So, and when you do a grip, you will be able to identify that the head will be unengaged, right? And there can also be early rupture of membranes in this case. Okay, just you have to identify if all these clues they give and ask you what position it is possible in this patient, then it is going to be a occipito-posterior position, right? Yes. Now as we are done with the examination part, I want you to know how many antenatal visits that a pregnant woman should have. Okay, so this question is also repeatedly asked. So, ideal number of visits that the patient can have is between 12 to 15. Let me tell you how this is. So, it will be monthly visits up to 28 weeks, then 2 weekly visits between 28 to 36 weeks, that is till your 9th month. Actually, we should speak in weeks only, okay? And every weekly from 36 weeks onwards till birth, okay? So, ideal number of visits a pregnant woman should have is 12 to 15, right? Now, there is a WHO ANC model which was given recently where they ask at least 8 visits should be taken by the pregnant woman. Okay, so they ask to take 1 visit in the first trimester up to 12 weeks, right? And in the second trimester, she should have 2 visits, one at 20 weeks and another one at 26 weeks. And finally, during your third trimester, she should have 5 visits. Okay, so one at 30 weeks, another at 34, then 36, then 38 and 40. Okay, suppose by 40 weeks she is not delivered, means then 41 weeks another visit will be there. Okay, so why this WHO ANC model I am telling means previously the minimum number of required visits by the pregnant woman was only 4. Okay, but now this has raised to 8. Okay, so remember the minimum number of antenatal visits that a pregnant woman should have is 8. Is that clear? Right. Now, let us see this picture where we are tossing the fetus like a ball over the abdomen, right? So, what is this? This is external ballotment. Questions on these are not asked. I am just putting it for the sake of completion of covering all your OBS images, right? And this external ballotment is usually seen between 20 to 26 weeks. And it is best elicited in breech position, and it is very difficult to elicit in case of oligohydramnios or obese patients. Yes. Now, this picture where pervaginal examination is done and the tossing is done using a single index finger. Okay. So, what they are doing, they toss it through the os and the baby is going to hitch over the uterine fundus and it is going to come back again. Again, you will feel the baby is coming and hitting your index finger. Okay, so this is your internal ballotment. Okay, so this is elicited best between 16 to 28 weeks of pregnancy, and this is also difficult to elicit in a obese woman and oligohydramnios, right? Now, coming to the most important point, yes, these are the fundal grips. I hope you will be able to tell this is first, second, third, fourth, okay, but let us know what is being identified here, what examination is done in the first maneuver. They are palpating the fundus. So, this is a fundal rib, and here they are palpating the lateral side of the fetus, right. So, this is a lateral rib, and here they are checking for the presentation. So, this is colic rib or Leopold's third maneuver, and this is your pelvic rib. Okay. Yes. So, this is Leopold 1, Leopold 2, Leopold 3 and Leopold 4. So, in Leopold 1, what they do? In fundal rib, otherwise, what do they do? Usually, they will be standing towards the mother's abdomen and they will be palpating the uterine fundus, right. So, you can have two options. Number 1, a soft, broad and irregular and relatively immobile structure is seen. That means, this is going to be your podalic end. Okay. If podalic end is at the fundus, means obviously the presentation is cephalic, right. The same way, if you are able to see a smooth, globular, hard and a ballotable part at the fundus, this is going to be a cephalic end. You see cephalic end at the top, it is going to be trouble. Yes, then the presentation is going to be a breech presentation, right. The same way, when you do a lateral rib or the second Leopold, you will be using both your hands and palpating the sides. 1, it can be fetal back. Number 2, it can be the fetal fingers and toes or the fetal limbs, right. So, when it is fetal back, it will be smooth, curved, and you will be able to get a hard feel. Okay. And the fetal limbs are usually knob-like. When you do the first pelvic rib or the colic rib, you will be just trying to hold the presenting part like this. Okay. So, in this part, the presentation and engagement are determined. And finally, the fourth grip, you will be doing this maneuver by seeing the feet of the patient. Okay, till now you are facing the face of the patient. This is the maneuver where you have to turn and see the feet of the patient, right? And this part is very important because it detects the presenting part. Then you will also be able to know whether engagement has occurred or not, as well as the attitude. Suppose in cephalic presentation, whether it is flexion or deflection or it is an extension. Okay, so that also will be able to make, right? So that is all about your what we have seen. Yes, the examination Leopard maneuvers. Okay. Now let us see some signs in pregnancy. Okay. So what sign you are able to see here? The cervix has become soft and pink, right? So this is Goodell's sign. Okay. So Goodell's sign is basically softening of cervix that is seen during your 6th week. Okay. And here you are able to see bluish discoloration of the cervix, right? So you are able to see bluish discoloration of the cervix. Basically there is congestion, okay, over the cervix as well as the vaginal mucosa. So this sign is your, yes, Jacquemus sign or Chadwick sign, that is usually seen during your 8th week of gestational age. And next comes your Higger sign. Okay, when they show a picture of bimanual examination, definitely this is going to be a Higger sign. What happens here is the firm cervix contrast with the softer fundus. Okay, and the incompressible intersposed softened isthmus will also be there. The isthmus will also be softened here. And this sign is also usually elicited between 6 to 10 weeks, right? They show a midline site of softening. So, this sign is your Ladden's sign. Okay, so this is also usually seen at 6 weeks, and here there is asymmetry of the uterine fundus, right? So, this is your von Braun Fernwald sign, von Braun Fernwald sign. Okay, so there is irregular softening and enlargement of the uterine fundus. This is noted between 5 to 8 weeks, right? Let us also discuss some of the other signs for which I don't have the peaks. So, it can be your Pisca sex sign, where one half of uterus is firmer than the other, okay, because there is lateral implantation here, right? And the next sign is Osiander's sign. This is commonly seen during 8th week, okay. So, O8, okay, 8th week. So, here you have increased pulsations that is felt through the lateral fornices, right? And the next one is Palmer's sign, where you have regular and rhythmic uterine contractions, okay, regular and rhythmic uterine contractions. This is also seen between 4 to 8 weeks. And last, we have something called as placental sign. Here, the patient will be having cyclical bleeding, okay. Cyclical bleeding can be seen in some cases, that is known as placental bleeding, even up to 12 weeks of pregnancy. Clear? So, yeah. So, these are the other leftover signs for which I didn't show pictures. Now, we have seen that bleeding will be happening with the placental sign. Now, what will be your other differential diagnosis when a pregnant patient who has got her UPT positive and has shown early signs of pregnancy in her ultrasonogram as well is presenting with bleeding? Yes, definitely you will be thinking about miscarriage, right? So, let us talk something about miscarriage or abortion, okay. So, when we talk about miscarriage or abortion, you should know that it can be a spontaneous miscarriage or it can be a medical termination of pregnancy, right? So, abortion can be of two types. Either it can be a spontaneous abortion or it can be a induced abortion, okay. You have so many types of spontaneous abortion. The types will include threatened abortion, inevitable abortion or incomplete abortion, complete abortion or missed abortion, right? Now, let us see the differentiating features between all these things. It is very important for you, right? Yes. Now, types of abortion. So, it is threatened, inevitable, incomplete, complete and finally missed. If you remember it in the same order, then it will be easy for you. First it becomes threatened, then it becomes inevitable, that is anyhow the abortion is going to happen, then it becomes incomplete, half of the products are passed, then complete, full products are passed, and missed means it has happened but it has been missed, right? Okay. Only a few of the differential features I am going to discuss here, we are not going to discuss it in detail, okay. So, in threatened abortion, the patient will be complaining of bleeding PV, and in inevitable abortion, this bleeding will be moderate to severe And in incomplete abortion, along with bleeding TB, she will complain of history of expulsion of products of conception. Okay. Then in complete bleeding, definitely this complete expulsion, she will tell that yes, I saw the complete expulsion of my products. Okay. And missed expulsion means that history of amenorrhea will be present, and she will be mostly complaining of brownish discharge here. Okay, she will be complaining of brownish discharge, and no such history of products of conception passage will be here, right? And the next point you have to know is about the vital signs of the patient. That is very important for the management. So, regarding the vital signs, in threatened abortion, the patient will be more stable. In inevitable abortion, there can be features of shock, okay, may be present depending upon the degree of bleeding, the patient may present with shock. And in incomplete abortion also the same thing, okay. And in complete abortion, the products has been expelled completely, so the patient will be more stable, as well as in missed also the patient will be more stable. Clear? And coming to the next point, that is per abdomen examination. When you do, the uterus will be equal to the period of gestation in threatened abortion, because nothing has happened, it is just threatening that it will get aborted, okay. And in inevitable abortion also, the uterine size will be equal to the period of gestation, and in incomplete abortion, half products has passed down, so it will be less than the period of gestation, and in complete also the same thing, okay. And what happens in complete means it will become almost normal, okay, it will be less, or the size will be almost normal, and in missed miscarriage, definitely it will be less than the period of gestation. Clear? Right. And the next point is pervaginal examination, okay. When you do pervaginal examination, the os is closed in case of threatened miscarriage, whereas in inevitable miscarriage, the os is opened, so that you will be able to feel the products of conception. The same thing in incomplete miscarriage also, okay. So, open and products of conception are felt, whereas in a complete miscarriage, products has already passed down and the os has closed, okay. So, here the os will be closed only, and in missed miscarriage also it will be closed. Clear? Right. And the next one is, now how will you treat these conditions? For threatened miscarriage, you have to give conservative management, whereas evacuation is needed in case of inevitable and incomplete miscarriage. And for complete miscarriage, nothing is needed. If needed, you can give conservative management, and for missed miscarriage, you have to do evacuation, right? So, this is all about your types of abortion, right? Now, let us also discuss about the induced abortion, that is MTP. MTP Act we have to discuss, okay. So, there was one MTP Act which was given in 1971, and there is a recent one which was implemented in 2021, okay. So, the difference between these two things is very important for you. Before 2021 amendment came, okay, so the contraceptive failure and MTP was availed only for married women, okay. Now, it doesn't say that woman and husband. Now, from 2021 amendment, it is woman and her partner, okay. So, both married as well as unmarried women can avail this MTP, right. And the second point is that limit of gestational age in 1971 was only up to 20 weeks, but now it has been extended up to 24 weeks, right. And the opinion required from registered medical practitioners will be 1 RMP up to 12 weeks and 2 RMP up to 20 weeks. But now it is 1 RMP till 20 weeks and 2 registered medical practitioners up to 24 weeks, okay. And if there is fetal abnormalities in 1971 amendment, it can be terminated till 20 weeks only, but here there is no limit on gestation. This is when congenital anomalies of the fetus are present, okay. So, this is what you have to know. These are the main differentiating features between these two acts. Clear? Right. Now,